Venetoclax Ibrutinib. Chronic lymphocytic leukemia, CLL. Treatment intent. Induction and maintenance of remission. First-line treatment of previously untreated CLL. Assessment. Ensure histology is confirmed prior to administration of therapy. Record stage of disease CT scan, neck, chest, abdomen and pelvis, presence or absence of B symptoms, cytopenias, clinical extent of disease, consider bone marrow aspirate and trophine. Blood tests FBC, ESR, DAT, U&E, LDH, G6PD, urate, calcium, magnesium, creatinine, phosphate, LFTs, glucose, Igs, 2-microglobulin, hepatitis B core antibody and hepatitis B surface antigen, hepatitis C antibody, HIV1+2 after consent. Genetic tests for 17p deletion, TP53 mutation, and IGHV mutation status. Urine pregnancy test, required before first cycle of chemotherapy in women of childbearing age unless they are postmenopausal, have been sterilized or undergone a hysterectomy. ECG plus or minus echo and baseline BP in all patients with a cardiac history or at risk of cardiac complications, hypertension, smokers, diabetes. Record performance status, ECOG. Record height and weight. Consent and counseling. Obtain written consent prior to treatment. Ensure pre-chemotherapy counseling in line with local trust guidelines. Assess and document baseline and pre-cycle 4 tumor lysis syndrome, TLS, risk. Patients should have full TLS risk assessment including a CT-NCAP in cycle 3, prior to the initiation of cycle 4, i.e., at the start of venetoclax. Patients with bulky disease and lymph nodes greater than 10 cm at cycle 4 should be referred to ambulatory care or inpatient ward for TLS monitoring during venetoclax ramp-up dosing that starts in cycle 4. Drug regimen.
Cycles 1 to 3. Drug.
Up or inpatient ward.
Days. Dose. Route. Administration details. Ibrutinib. 1 to 28. 420 mg once daily. Oral. Take it at approximately the same time each day. Swallow tablets whole with water. Available as 420 mg, 280 mg, 140 mg. Cycle frequency, every 28 days. Cycle 4. Drug.
Up or inpatient ward.
Days. Dose. Route. Administration details. Ibrutinib. 1 to 28. 420 mg once daily. Oral. Take it at approximately the same time each day. Swallow tablets whole with water. Available as 420 mg, 280 mg, 140 mg. Venetoclax asterisk. 1 to 7. 20 mg once daily. Oral. Take in the morning with food. Swallow tablets whole with water. Available as 10 mg, 50 mg, 100 mg. 8 to 14. 50 mg once daily. 15 to 21. 100 mg once daily. 22 to 28. 200 mg once daily. Cycle frequency, every 28 days. Cycles 5 to 15. Drug.
Up or inpatient ward.
Days. Dose. Route. Administration details. Ibrutinib. 1 to 28. 420 mg once daily. Oral. Take it at approximately the same time each day. Swallow tablets whole with water. Available as 420 mg, 280 mg, 140 mg. Venetoclax asterisk. 1 to 28. 400 mg once daily. Oral. Take in the morning with food. Swallow tablets whole with water. Available as 10 mg, 50 mg, 100 mg. Cycle frequency, every 28 days. Treatment duration, until disease progression or unacceptable toxicity up to max 15 cycles.
Missed doses. Ibrutinib. If a dose is not taken at the scheduled time, it can be taken as soon as possible on the same day with a return to the normal schedule the following day. The patient should not take extra tablets to make up the missed dose. Venetoclax. Missed venetoclax dose within 8 hours of the time it is usually taken, should be taken as soon as possible on the same day. If a dose is missed by more than 8 hours, it should be omitted, and the usual dosing schedule resumed the following day. If a patient vomits following dosing, no additional dose should be taken that day. The next prescribed dose should be taken at the usual time the following day. For patients who have had a dosing interruption lasting more than 1 week during the first 5 weeks of dose titration or more than 2 weeks after completing the dose titration phase, TLS risk should be reassessed to determine if restarting at a reduced dose is necessary. Table 1. TLS risk assessment, cycle 1 and 3, management and monitoring.
TLS risk. Low, moderate, high. TLS risk assessment. All LN less than 5 centimeters. And ALC less than 25x109/L. Any lymph node 5 centimeters to less than 10 centimeters. Or ALC greater than or equal to 25x109/L. Any lymph node greater than or equal to 10 centimeters. Or any LN greater than or equal to 5 centimeters. And ALC greater than or equal to 25x109/L. TLS management. Oral hydration. And allopurinol. Oral and/or for hydration. And allopurinol. Oral and intravenous hydration and allopurinol and rasburicase. TLS monitoring. Cycle 4 day 1, 8, 15, 22 and cycle 5 day 1. Predose, 6 to 8 hours and 24 hours post-dose. Outpatient. Outpatient or ambulatory care. Ambulatory care or inpatient.
Restaging.
Clinical response should be assessed monthly for the first 5 months. Patients on ibrutinib can develop worsening of lymphocytosis for the first 4 to 14 weeks, and response cannot be assessed by a drop in lymphocytes. Formal restaging should be performed by CT during cycle 3 to guide TLS risk assessment pre-cycle 4. Subsequent CT scans should be considered every 3 to 6 months.
Contraindications. Hypersensitivity to ibrutinib or venetoclax. Patients should avoid consuming grapefruit or grapefruit products, Seville oranges, including marmalade containing Seville oranges, or star fruit within the 3-day period prior to the first ibrutinib and venetoclax administration and until the last day of treatment is completed due to possible CYP3A-mediated metabolic interaction. Dose modifications. If a patient discontinues either ibrutinib or venetoclax for reasons other than disease progression, the other drug should be continued, unless otherwise indicated by the treating consultant, up to maximum 15 cycles of ibrutinib and maximum 12 cycles of venetoclax. Ibrutinib. Hematological and non-hematological toxicities.
Grade greater than or equal to 3 non-hematological. Grade greater than or equal to 3 neutropenia with infection or fever. Grade 4 hematological. Toxicities. Interrupt ibrutinib. Once symptoms of toxicity have resolved to grade 1 or baseline, recovery, reinitiate ibrutinib at the starting dose. If the toxicity reoccurs, reduce dose by 140 milligrams. A second reduction in the dose by 140 milligrams may be considered as needed. If toxicities persist or recur following 2 dose reductions, discontinue ibrutinib. Renal impairment. CRCL less than or equal to 30 milliliters per minute or on dialysis. No data. Use only if benefit outweighs risks. Monitor closely. Hepatic impairment. Child-Pugh Class A, 280 milligrams OD. Child-Pugh Class B, 140 milligrams OD. Child-Pugh Class C, no data. Use only if benefit outweighs risks. Monitor closely.
Venetoclax.
Interrupt venetoclax. Grade 3 or 4 neutropenia. First, to reduce the infection risks associated with neutropenia, granulocyte colony stimulating factor, GCSF, may be ANC 1x109/L with occurrence. Administered with venetoclax if clinically indicated. Infection or fever. once the toxicity has resolved to grade 1 or baseline level. Or, venetoclax therapy may be resumed at the same dose. Grade 4 hematologic. Second and subsequent occurrence. Interrupt venetoclax. Toxicities except. Consider using GCSF as clinically indicated. Lymphopenia. Follow dose reduction guidelines when resuming, e.g., ANC 0.5x109/L. Treatment with venetoclax after resolution, or platelets 25x109/L. Additional dose reductions may occur at the discretion of the treating consultant.
Venetoclax, CONT. Non-hematological toxicities.
Tumor lysis syndrome. Any occurrence. Withhold the next day's dose. If resolved within 24 to 48 hours of last dose, resume at the same dose. For any blood chemistry changes requiring more than 48 hours to resolve, resume at a reduced dose. If rapid dose escalation is required due to progressive disease, patients must be admitted for hydration and management of TLS. For any events of clinical TLS, resume at a reduced dose following resolution. See Table 2 below. Grade 3 or 4. Non-hematological toxicities. First occurrence. Interrupt venetoclax. Once the toxicity has resolved to grade 1 or baseline level, venetoclax therapy may be resumed at the same dose. No modification is required. Second and subsequent occurrences. Interrupt venetoclax. Follow dose reduction guidelines when resuming treatment with venetoclax after resolution. A larger dose reduction may occur at the discretion of the treating consultant. Renal impairment. CRCL less than 80 ml/min. Consider increased risk of TLS. At discretion of the treating consultant, more intensive TLS prophylaxis and increased TLS monitoring may be recommended. CRCL 30 milliliters per minute. No dose adjustment required. CRCL less than 30 ml/min or dialysis. No information available. Clinical decision. Hepatic impairment. Mild moderate, child Pew. A or B. No dose adjustment. Patients with moderate impairment should be closely monitored for toxicity. Severe. Child Pew C. Reduce dose by 50%. Monitor closely for signs of toxicity.
Venetoclax dose modifications for toxicities.
Dose at interruption. Restarting dose. 400 milligrams. 300 milligrams. 300 milligrams. 200 milligrams. 200 milligrams. 100 milligrams. 100 milligrams. 50 milligrams. 50 milligrams. 20 milligrams. 20 milligrams. 10 milligrams.
Continue the reduced dose for 1 week before increasing the dose. Concurrent medications.
TLS prophylaxis. Allopurinol 300 milligrams, reduced dose in renal impairment, for 7 days, Ibrutinib initiation in cycle 1, and then 35 days, venetoclax ramp-up dosing in cycle 4 and first week of cycle 5. Unless otherwise indicated in TLS risk assessment, see Table 1 above. Antiviral prophylaxis. Acyclovir 200 milligrams 3 times daily for duration of treatment. PHP prophylaxis. Cotrimoxazole 480 milligrams 3 times a week on Mon/Wed/Friday, or twice weekly during neutropenic periods for duration of treatment. GCSF. Consider the discretion of treating clinicians when clinically indicated.
Warnings and special precautions. Ibrutinib. Cases of ventricular tachyarrhythmia have been reported. Temporarily discontinue ibrutinib in patients who develop symptoms suggestive of ventricular arrhythmia, including palpitations, chest pain, dyspnea, dizziness, or fainting, and assess benefit-risk before restarting therapy. Be aware of the risk of hepatitis B virus reactivation and establish hepatitis B virus status before initiating therapy. For patients with positive hepatitis B serology, consultation with a liver disease expert is recommended before the start of treatment, monitor and manage patients according to local medical standards of care to minimize the risk of hepatitis B virus reactivation. Consider prophylaxis according to standard of care for patients who are at an increased risk of opportunistic infections. Venetoclax. Tumor lysis syndrome, TLS, remains a serious risk of venetoclax therapy, although has not been reported in the Ibrutinib plus venetoclax clinical trials. The TLS risk must be assessed based on multiple factors, including tumor burden, comorbidities, particularly reduced renal function, and splenomegaly. Patients should be advised to stop taking venetoclax and seek medical attention immediately if any of the symptoms of TLS occur: fever or chills, nausea or vomiting, confusion, feeling short of breath, irregular heartbeat, dark or cloudy urine, feeling unusually tired, muscle pain or uncomfortable joints, fits or seizures, abdominal pain and distension. Adverse reactions. Ibrutinib monotherapy. The most common adverse reactions, greater than or equal to 20% diarrhea, fatigue, thrombocytopenia, neutropenia, musculoskeletal pain, upper respiratory tract infection, nausea, hemorrhage, e.g., bruising, rash, pyrexia, arthralgia. The most common grade 3/4 adverse reactions, greater than or equal to 5% neutropenia, thrombocytopenia, lymphocytosis, hypertension, and pneumonia. Cases of atrial fibrillation and atrial flutter have been reported particularly in patients with cardiac risk factors, hypertension, acute infections, and a previous history of atrial fibrillation. Periodically monitor all patients clinically for cardiac manifestations, including cardiac arrhythmia and cardiac failure. Patients who develop arrhythmic symptoms or new onset of dyspnea, dizziness or fainting should be evaluated clinically and if indicated have an electrocardiogram, ECG, performed. Hypertension is commonly associated with ibrutinib, and regular monitoring is indicated, ideally using ambulatory monitors. Coexisting hypertension needs proactive management. Other adverse reactions: stomatitis, constipation, dyspepsia, urinary tract infection, sinusitis, peripheral edema, asthenia, petechiae, muscle spasms, epistaxis, dizziness, headache. Venetoclax and ibrutinib combination therapy. Incidences of diarrhea and neutropenia were higher than with ibrutinib alone. 0.8. The most common adverse reactions, greater than or equal to 30%, of any grade: diarrhea, nausea, neutropenia, arthralgia. The most common grade 3/4 adverse reactions, greater than or equal to 5% neutropenia, hypertension. Thank you.